So welcome, everyone. Thank you, Helen. It's really good. And also the Goodfellow Unit. So I think you've had a really great series of these webinars, and it's the last one of the year. And we also had two really good sessions previously, the last Tuesdays, on the chronic pain and fat. So now we're really focusing at the other end of the spectrum, which is to do with chronic pain, and possibly focusing, actually definitely focusing a little bit more on drugs. It was interesting, I'd had a patient recently describe to me her chronic pain when we were looking at chronic pain and calling it just useless pain. And it was sort of an interesting description, I thought, because it meant, oh, so is acute pain useful? And yeah, acute pain can be really useful. But what we've got to do is prevent it going through past its use-by date and ending up being sort of more chronic, persistent pain. So first of all, I'd like to sort of declare, first of all, I do get a bit conflicted about using some of the analgesics and who to use what for, but I have no conflicts of interest as such. So sort of moving on, we actually found that there's pretty much a limited place for pharmacotherapy or drugs in the use of chronic or persistent pain. And so now we're sort of looking at acute pain. And we thought we had it probably under control, and we do probably for the majority of people. But unfortunately, we're finding the more we learn, the less we actually know. And so we've got a lot of experience, but the evidence is coming out looking a little bit different. And I'm sure some of you are becoming well aware of the sort of meta-analyses that are coming out, particularly with paracetamol, saying, oh, paracetamol is not really effective at all, so what are we going to do? Then the sort of next bit's coming out saying, what about non-steroidals? Well, they're marginally better perhaps, but there's those embarrassing and very evident adverse effects that occur, the ones that patients end up in hospital for, with their GI bleed and renal. So, and in honesty, still we have one of the highest admission rates. If we're looking at medicines-related admissions, it's to do with the antithrombotics and the non-steroidals. So that's becoming a problem, and then particularly if you're in the States, we start looking at what about the low-potency opiates. Again, the evidence for that is that they're not very effective, and they also have adverse effects. Also, they tend to be a little bit more subtle than the adverse effects of the non-steroidals. Things like falls, confusion, there is some increased mortality. As I said, unless you're in the United States, where it's very obvious the overdose deaths that are occurring and the addiction. So acute pain perhaps is a little bit more challenging than we would have thought. One of the things that we're actually finding, though, with our increasing knowledge is that one of the most important factors is not only the individual and the potential adverse effects, it's also about you as the providers and what's happening with acute pain and chronic pain. There is actually no magic bullet when it comes to an ideal analgesic, so we've just got to make the best of what we've got in our armoury and also go into a lot of risk mitigation strategies. So what are we going to do in the next hour or so? Very brief background, because I don't think you want to sort of go into massive backgrounds on this, and then we'll get into a particular case, and we'll actually look at, we're going for gold, it's the end of the year, push the boat out, we'll look at acute back pain because that seems to be quite a common one, and mixing that with musculoskeletal, very briefly mixing that with musculoskeletal issues. The pharmacological choices are pretty obvious. We have our three main ones, and then we have the we don't know what to do now, and so we have adjunctive medicines, which is sort of getting to the helpless stage. While we're dealing with patients and particularly moving forward in joint decision making, it's obviously an issue of the benefits and the risks that are important, and trying to quantify those. For that, we'll look at those. And dental pain. I won't say what about dental pain. That's quite relevant. It'll be very short though. And then the key points. So quickly, by way of background, pain is a continuum, and it changes over time. And as you'd sort of learned from the chronic pain lecture that we had a couple of Tuesdays ago, if pain persists, it causes physiological changes, and we ended up with more complex therapies, and usually there are a lot of the talking therapies and a lot of exercises. And the pharmacotherapy becomes a lot less relevant, as well as the fact that opiates may well end up aggravating the pain through sensitization. So if pain's going to last more than 3 to 6 months, probably time to start thinking about referral or taking a different approach. And being in primary care, referrals often going to mean trying to get some way of getting some psychological services. As Helen mentioned, the new ACC pain management contract is out there, and it seems to be really helpful because the core team that you'll be referring people to is the physiotherapist, a pain specialist, and a clinical psychologist. So just in the past, it's been hard to get help when we get to that 3 to 6 month stage where pain's persisting. Now there is actually services that you can refer to. So pain's, as we talked about, very individual. People react quite differently. It's influenced when the person comes in, you know, it's what their mood's like, have they got anxiety, what's their sleeping like, and are they the sort of person that does quite a bit of catastrophizing? So that's going to be really part of your consultation. And I'm going to talk about drugs rather than that. When we look at the studies that are actually involved in the randomized controlled trials, a lot of them are post-operative, so that's really acute, really clear, and a particular type of pain, or dental pain, because that's one of the worst types of pains. And when you look at the randomized controlled trials, they deal with averages. So just going back to the paracetamol, on average, the paracetamol has minimum effect for people with osteoarthritis or back pain. So it's pretty marginal. But remember, there's still there a minority perhaps of people that do respond really well. So it's not that we're going to throw it out and that. Also, when we talk about the studies, if you see the studies that say, oh, the number needed to treat for amitriptyline, for peripheral neuropathy, the number needed to treat is 4. That's really, really good. I think it's important to remember that what they consider a good response is a 50% reduction in pain. So that's a good response, and we have to be very careful and very clear when it comes to the expectation of analgesia with patients as well, is that, you know, a good response is a reduction in pain. That number needed to treat didn't mean to say that 1 out of 4 people is going to end up with no pain at all if we use amitriptyline. Some will, but not all. So basically, the individual response tends to trump the drugs. So the person's attitude and what you say to the person, the context that you put it in, is going to be the things that will tend to trump drugs. The other one that's absolutely crucial, and that's your explanation, your assurance, and managing the expectations of what the people should expect. So people sort of come in and they've got pain. They think that that means that if they've got pain, then there's damage being done, therefore they stop what they're doing, they don't do it, and they start losing muscle mass, or they start losing muscle strength. So if you take an aged person, someone over 75, if you take that person and you give them bed rest for 24 hours, the chances are that they'll have lost 10% of their muscle strength within that 24 hours. So this happens even with younger people, although it may not be as noticeable. For those of you that are old enough, some of you won't be, but when we had RSI, the idea way back last century was that you immobilized it. You had RSI at the wrist, so you immobilized it. And what happened then is that people lost the muscle strength, and when they started to do exercises, the pain came back. So all these sort of things are quite important that are explained to the person, and that activity, even though they have pain, is really important. The other one, which a person with back pain doesn't really want to know at the time, remember that smoking increases sympathetic tone, and therefore it also increases pain. So that's a good time to be perhaps recommending that people give up smoking, perhaps not. Okay, so this is really an arbitrary case. So you've got Ms. Y. She's one of the young sort of Y generation, 27 years old, she's really in very severe pain, probably lucky she managed to get in to see you because it was so painful. She's had to sit in the car to get to you. So this is someone who's in really bad pain. And what she said is she threw her back out. It tends to be the terms that people use. Normally, she's basically a fit, healthy young woman. And when you have a look, there's no red flags. So this is the case we're looking at, very briefly. And what we have at the end is but what if it's someone with ischemic heart disease? What if it's a Māori or Pacific person? What if they're over 65 or over 75 years old? So before we get into the drugs, this is something that's really nothing new to you. It's what your everyday practice is having a look at, well, asking the people, what's your idea? What do you think's happened to your back? And they sort of tend to think that their back is very fragile, and that, as I said, the pain means that, oh, I can feel pain, my disc's about to pop out, or my back's about to get permanently damaged. So you've got a lot of roles there when it comes to actually education and letting people know what the problem is. They're concerned that they won't be able to get back to work. They're concerned that their back's going to be a problem for all their lives. So they're the sort of concerns coming up. And what they expect, if they're not catastrophizing, is they expect that you're going to prescribe something and they'll be able to resume their normal activity pretty much immediately, and perhaps, with no pain. So the important thing is really to start with the end in mind. So that's starting at the very beginning with that reassurance, explaining the pathophysiology, the fact that discomfort is not an indicator necessarily that damage is being done because the damage has occurred, but that they can still work through that. And I think looking at what some of our GPs working with them do, they'll ask someone, how far can you stretch, or how far can you move at the beginning, and then they'll talk to them and they'll ask them again, and the person can move a bit further. So it's identifying for them that they can make that movement. So the other one is that analgesics aren't actually going to cure, or basically they're not going to heal or cure the back pain. They're merely there as a temporary measure to help reduce the pain so that activity can occur. So that sets an expectation that this is not something that is going to be long term. They're basically that kickstart for those. I guess the other one is, as you're all aware, is giving them an expectation that, well, actually 2 weeks things will get better, but these backs can take 6 to 12 weeks to totally resolve. Okay. So let's start with paracetamol. Basically, here's our go-to drug, and what the heck, has it actually sort of got up and gone? So it's a little bit of a problem. Interestingly, we still don't know the mechanism of paracetamol. The latest one I find quite interesting is it a cannabinoid agonist? So that's very topical at the moment. Before that, we're thinking maybe it's a COX-2. Despite the bad press, as I said, you've sort of got the meta-analyses that says paracetamol is not all it was cracked up to be. Despite that, you've all had experience of using paracetamol, using it for your patients, and it usually works pretty well for mild to moderate short-term twinges, aches and pains. I don't know, most of you have probably taken paracetamol and found that it works. So it's still there. If we look at it for post-operatively, there's a lot of studies that show even post-operatively for, moderate type pain post-operatively, that it's still working in that. The idea of it working for some people is, a couple of months ago, I had a person who was in chronic pain, and she really didn't like taking all her medicines, of which there were a lot. And she wanted to cut down. And so with discussion, she was saying, but it's only paracetamol. I think I can stop the paracetamol. And so we worked out a plan, and we went slowly about this. You never want to do anything too quickly with people with chronic pain. And so we started slowing, withdrawing the paracetamol from 1 gram QID to 3 times a day, and then wait for 2 weeks, and then we'd reduce it again. And it was quite an eye-opener, because by the time she got down to 2 tablets twice a day, her pain had come back really, really badly, and we immediately started the paracetamol again, and it improved. So whatever was happening, for her, paracetamol was something that was working, and we won't know unless we try. The other one about use of paracetamol is using it regularly, and I would often say to people, when you're going to do it, just use it for 5 days, 4 times a day. And then at the end of that, either it's working and that's really good, and you can be in control of taking less if you like. You're able to take it twice a day or 3 times a day. But if after 5 days of using it regularly and it's not working, then we'll try something else. When we get to the end, that's not what we're going to do. This patient's, or the case that we've got, her pain is obviously far too severe to actually attempt that. But for many cases where you've got sort of mild, moderate pain, you could just try taking it regularly for a certain amount of time and then let the patient decide. I've put in there that concept of a nocebo. As I said, paracetamol works really well for me, and I've read the study that says even giving somebody an open label placebo is really effective. And is effective with paracetamol. I just find that particularly interesting, and I don't think I'll go much further. It just says that the person's mind is perhaps more important than our drugs and what they think and perceive. Okay, so the concerns at the moment that's coming up, and our own Quality, Safety and Health Commission has actually published something, and it's to do with the adverse effects of paracetamol. We've always said, oh, paracetamol, not very toxic at all, what's the problem? There is chronic hepatotoxicity that does occur. We're finding now that people who have been taken a long time do have disturbed liver enzymes coming in, and some of the liver transplants that have come in, they've looked at, particularly for children, though, is more of a chronic toxicity than an acute toxicity. So there are adverse effects with paracetamol, as well as potential GI bleeding and the renal issues. When it comes to our older people, and we thought paracetamol was safe, and we're saying, oh, 1 gram 4 times a day, frail, malnourished people, really important that we probably just go to a maximum of 3 grams a day. So that's 1 gram 3 times daily. And be careful that they don't get dehydrated in that. And for people having a lot of alcohol, because alcohol inhibits the metabolism to inactive metabolites of the paracetamol in one situation, and the other one, it actually increases the metabolism to the toxic metabolites. So if you've got someone who does have quite a bit of alcohol, they should limit their paracetamol. And that sort of covers the interaction that we've got there. The other one that's quite important is the interaction with warfarin. If paracetamol is under 2 grams a day, then you're not going to really notice a difference, and you would see a difference in INR if it was greater than 2 grams a day. So it's the people that take the odd sort of paracetamol, then suddenly say they do have some sort of musculoskeletal injury, something like that, and they start taking paracetamol regularly, then that's the time to actually consider that there's an interaction with paracetamol. So as soon as they get up to 3 times a day, watch out for the INR. The other one is prescribing amounts. Paracetamol is still the most common poisoning or overdose that comes into EDs in New Zealand. There's a lot of paracetamol there, the way it's being prescribed. And I noticed when I've had a few patients that it keeps sort of coming back, and I think they're using quite a bit. And I say, well, how are you taking it? Well, I'm taking it 4 times. It says 4 hourly, so I'm taking it every 4 hours. So I probably just make a plea on the prescribing of it that not to use the Q4H, but perhaps more on the instructions to say taking it for pain up to 4 times a day. Because some people do continue taking it, and as I said, chronic toxicity is becoming more of a problem now. So that's sort of looking at the paracetamol. Or just when it comes to sort of recommendations on that, for paracetamol, mild to moderate pain, certainly give it a go. See if it's actually going to work for that person for that. But if they come back and say it's not touching it at all, don't persist with paracetamol, and don't even use it as one of those that we used to say, we'll use it for baseline pain relief so that we don't need to use so much non-steroidal. If it's not going to work for the person, it's not going to work. So we get to paracetamol. The evidence here is that it might be marginally better than paracetamol in back pain and in osteoarthritis, but in back pain it might be marginally better. But our experience probably says that in fact it's a lot better. So this is where we have our problem with what the evidence says and what our experience is. It might be when you're giving it to the person, you are very positive about how well it will work. The problem we come up with, of course, though, is that the issue, the patients, when you're trying that they shouldn't take, and I had a patient come in and it was, I know, I've been told it's really, really bad for my kidneys and that, but I found some old tablets and I just had to use them because I don't care. The pain was so bad, I don't care about my kidneys. So we're often in a dilemma that the patients think that these medicines are absolutely wonderful. And it's very hard to get them off it, and it's very hard to tell them that there are some risks involved. Going back to the short term, what is of interest is that if required non-steroidals when you're using them, they are not actually anti-inflammatory, they're just analgesic in their actions. And it really does take, it can take sort of, although the effect will come on really quickly, which is the analgesic effect, if we're looking at them as anti-inflammatories, it can really take a week or so before we start getting the anti-inflammatory effect on these, and sometimes even up to 3 weeks. So just to be aware, we say these are anti-inflammatory and they're going to take away the inflammation. Initially, they are just an analgesic effect. There's very little difference between the non-steroidals. Everyone has their favourite. Marginally, it might be that ibuprofen is less of an anti-inflammatory. It can work as an analgesic, but it's possibly less of an anti-inflammatory action. In New Zealand, we're probably looking at naproxen and diclofenac as the main medicines. The intra-individual response is, if you give any of your favourite non-steroidals to a person, about 60% will respond, and it doesn't matter what the non-steroidal is, 60% is likely to respond. If someone says it's not working, then just try another non-steroidal. And I get the feeling in New Zealand that would be alternating between naproxen, diclofenac and ibuprofen, but there is that intra-individual response. So try another non-steroidal, perhaps before you might think about using an opiate. Next problem we have is with the patient that came in and didn't really care about his kidneys because the pain was so bad, is trying to quantify the benefits and the harms. It would be really handy if we could do that. So everybody knows, this is not news, that gastrointestinal adverse...
Sorry, Linda, can I just interrupt for a second, just before we go on with the NSAIDs? We have a couple of questions about paracetamol, one of them being that mildly deranged LFTs are fairly common, and how do we identify those who are experiencing paracetamol toxicity versus normal population?
Yeah, I think the mildly deranged means that start sort of thinking about, actually, should they be on that dose of 1 gram 4 times a day? It is a dose response. Yes. So you'd be starting to suspect that they are taking more than they're taking 4 times a day, and that it's going to be a problem for them. So it would really be telling the person to go backwards and 2 or 3 times a day, and you'd probably be thinking about, well, maybe I have to actually use a different analgesic on that. They sort of rumble along. Difficult because thinking more of perhaps people with osteoarthritis, remembering that fatty liver might look, non-alcoholic fatty liver might look pretty much the same.
Sure.
So
and
it's go on.
Sorry, there was a mention of the written guidelines that Australia has produced that are available online for paracetamol use. Are you aware of those?
I'm not. I'm sort of probably make a sort of guess on the fact that they're not that keen on it, because I know one of their leading rheumatologists, David Hunter, doesn't like paracetamol at all.
Right, okay.
But someone write what they are. I mean, the other one is I can actually look and make a comment in writing at the end of this.
Sure. The last thing about the paracetamol was, if someone has pre-existing deranged LFTs, presumably should they have reduced dose of Panadol to start off with?
Right. So if like fatty alcohol, non-alcoholic fatty liver or something like that, it would probably be again like 3 grams. It's just an additive perhaps effect that you're looking at on that, so that it's not like you can't use that at all. It's just that we'd just be a little bit wary about the dose.
Great.
So 3 grams. Watch out for those people with non-alcoholic fatty liver. Okay, and I will look up the Australian guidelines. As I said, it was sort of, I would assume that their issue will be to do with paracetamol. If David Hunter had much to do with that guideline. Okay, so non-steroids. So the adverse effects, gastrointestinal, everyone is probably well aware of the gastrointestinal effects of that. Most, well, 25–50% are going to get some sort of dyspepsia. Dyspepsia can be treated with ranitidine or with a proton pump inhibitor. If people get dyspepsia, that doesn't mean that they're more likely to end up with a gastric bleed. If someone gets a gastric bleed, it's pretty much can be asymptomatic because the person's getting pain relief, and so they end up coming in with, throwing up a whole lot of blood or melena. So dyspepsia itself isn't a alarm that you're going to get a gastric bleed. So it can be treated with simple therapy, be it a ranitidine or with a proton pump inhibitor. The actual gastric bleeding, the risk is greater in the first 3 months, and so then gets less, but the first 12 months, and then they say that the gastrointestinal tract sort of adapts, but you're still going to have an increased risk, and particularly if you add other medicines. So when you're talking to the person, it's one out of 100, say, and that's 3 times. So if you use those little smiley faces, you can say, here's 1 out of this 100. And if you weren't using a non-steroidal, then here's sort of the fact that it's, well, it's a third, which doesn't look so good on your smiley faces. But that's the sort of thing you could use. The number needed to harm, probably, as you can see there, is about 110. But it does depend on the underlying risk of having a bleed. So I've put in there the has bled score people are far more familiar with when using it for atrial fibrillation. I think of it, because I like the acronym there, is to remind me really about the risks for that person that puts them at increased risk of bleeding. And so obviously they're sort of labelled there with hypertension, because I've got a history of a GI bleed. The surprising one is the medication, and it makes a lot of sense, obviously, if we're looking at warfarin, we're looking at dabigatran, aspirin, clopidogrel. These medicines you won't see for warfarin an increase in the INR because it's an additive effect. The ones that surprise people is the use of the SSRIs, because part of their action is an antiplatelet, which happens, so it's the serotonin and the platelets. And the same with tramadol, because tramadol has an SSR action. So just to be a little bit wary with the non-steroidals, it's not a massive increase, but it's certainly a bit of an increase, and prednisone. The recommendations of what are you going to do with it is obviously the use of a proton pump inhibitor. The UK suggests a proton pump inhibitor with anybody. Would certainly say anyone who's over 65 years old, or anyone who's got any other risk factor as labelled above there, and those on aspirin as well, or SSRIs. It's cascade prescribing, so that causes us a fair bit of concern, but it's going to reduce the risk of a bleed by about 50%. Go back to the smiley faces. Celecoxib, yeah, Celecoxib is now around. We will talk very briefly about the precision study, which is being marketed at the moment, but there's no denying that when it comes to reducing the gastrointestinal adverse effects, then it reduces the risk about 50%, maybe a bit less. The idea is if someone's still at high risk of bleeding, because it's reducing the risk, it doesn't negate it. You can throw in a PTI for that as well. Celecoxib and aspirin, you probably have back to the normal risk of a bleed. So unfortunately, we'll probably see a bit more of the cascade prescribing. PPIs are not very popular, but in this case, they're going to be quite important. Okay, the next one, and this patients do seem to be a bit worried about their kidney. 40%, as you can see, of the reports to come of anything to do with renal have to do with diclofenac, and that doesn't include the other non-steroidals. It's not just old people. Although age is a risk factor, it's some of the young people with their sports injuries and they go out and they get dehydrated. So be very wary of young people when they start chomping away on the non-steroidals, particularly if they go out, because it now means they can do some exercise and they become dehydrated. I think I looked at the hospital admissions and it was pretty evenly, or the CALM results as well, it was pretty evenly spread across the age groups. So youth doesn't protect you necessarily. Obviously, people with microalbuminuria are going to be at greater risk as well. So it's people with diabetes you'd be a bit more concerned about because they're already heading down the track with some renal damage. And the other one, which might be a little bit controversial, is for Māori and Pacific people. And in general, Māori and Pacific are more likely to end up with end-stage renal disease and poor renal function. And that's not necessarily just people with diabetes. So this is sort of being looked at, and they say there's genetic factors, there's biological factors, there's environmental factors, and they're trying to sort that out. But there is a view that for Māori, perhaps the nephrons are biologically different, and whether it's because they're shorter or because they don't have as many, it's obviously being studied. But I am getting a lot more concerned about Māori and Pacific people having non-steroidals. And having looked at their renal function, you can see that I'd recommend definitely checking their renal function in 7 to 10 days. I have found that they seem to be more likely to have a reduction in renal function. I think that's sort of more to do perhaps with gout as well. And so if someone has gout, Māori or Pacific with gout, I'd be more inclined to treat them with prednisone than I would with a non-steroidal at this point. So not very clear data about why the problem is there, but certainly probably enough to make us think, not so sure. Remember that as with gastro and with renal, it's dose related on those. The avoiding people, creatinine clearance, so in your older people, remember that eGFR usually overestimates renal function, so it's worth doing a quick calculation for creatinine clearance. If it's less than 50 mils, good idea to avoid. When I looked up the evidence and the studies behind this, you know, there is the ability to use it perhaps weighing up the benefits for that person if they really get pain relief from it and the risks. The risk mitigation is the person has to agree that they will have those extra blood tests to make sure that their renal function is being maintained, and also that they don't get dehydrated, going back to that dehydration. Don't get dehydrated. Conservatively though, creatinine clearance less than 50 mils a minute, really try and avoid a non-steroidal, and checking renal function. Oops, I think I might have, I'm just going to see if I can go previously. Oh, that's okay. I was going to have a look at our triple whammy. So I'll just go back there. The triple whammy is, I see that it even got rated in one of the national newspapers, if you consider the Dominion a national newspaper. that all these problems that are occurring with the triple whammy. The triple whammy being having an ACE inhibitor or an angiotensin 2 antagonist, plus a non-steroidal or a COX-2, or having a diuretic, or someone being dehydrated. If you have a look at that, the number needed to harm of throwing in a non-steroidal with the ACE inhibitor, say, and the thiazide, the number needed to harm is about 150. And it's enough that you'd probably think you can either stop the diuretic, unless it's furosemide for heart failure, but you're probably not going to use a non-steroidal in heart failure anyway, or basically stopping the thiazide for high blood pressure and going from there. So be very wary of that combination. It is causing a lot of people to be hospitalized, as said, particularly with the dehydration. Again, you'd certainly avoid that with people, that combination of people who had creatinine clearance less than 50 mils. The next one that's causing more controversy, mainly because it's very hard to quantify, and that's the cardiovascular risk. Is there anything about non-steroidals that it's looking good, other than the fact that they seem to be effective for some people? We used to think the naproxen might be a little bit cardioprotective because it didn't look as if it was going to be such a problem. But looking at individual patient level data in a big study from the BMJ, all non-steroidals increase the risk of a cardiac event, so fatal or non-fatal MI or stroke, by 20 to 50%. More difficult because we're talking about acute pain, so you'll be giving people the non-steroidal for a short period of time, and then they might stop and then they'll start again. The greatest risk appears to be in the first month. It's probably not necessarily related to an increase in systolic blood pressure. It's probably more to do with a coagulation issue. But just to be aware that blood pressure can go up 4 to 5 millimeters of mercury. So one of the risk mitigations will be to keep monitoring that blood pressure. The number needed is, again, you can actually point this out to the patient. How they perceive this would be quite different, but 3 major cardiovascular events in 1,000 people per year. It's very hard to know how they perceive that. When we say to people there's a there's a rare chance that you might have a myocardial infarction, their perception of what rare means is quite difficult, but this is as good as we can get with quantifying it. The dose, you can see the doses there. This is probably more a concern again for acute pain. When we start looking at people using diclofenac, 75 milligrams, it's acute pain. So, you say we can use that up to twice a day. But if you've got someone with an underlying fairly high cardiovascular risk, this is getting a little bit hazardous at that point. So you might be wanting to just do the 75 milligram or 100 milligram daily for those people. Remembering you don't negate the risk, but at least you mitigate it. Same with ibuprofen and Celecoxib. Definitely contraindicated within the first 12 months after a myocardial infarction, and you have to consider the underlying cardiovascular risk. Someone comes in and their cardiovascular risk is 5%, because you've all done the cardiovascular risk assessments. They come in with a risk of cardiovascular, 5% for that. You're going to add on, say, 20 to 50% of that, as well as using a low dose. Then their risk is barely going to go up to 6%. So for them, that's a very small increase for what might be a very good benefit in terms of pain. Someone coming in with a 30% cardiovascular risk, and you're going to increase that by 20 to 50%, then you'd have to start really thinking about what that risk is going to be. So it is those at the higher cardiovascular risk, and of course, avoid them in heart failure. I think most people have seen the effect that non-steroidals have on people with heart failure when they come in with a bit of edema. Just quickly going through these ones, looking at respiratory, asthma. This is more the risk. People will have been taking non-steroidals perhaps, so it's just the risk factors, and the main one really is the nasal polyps, so that's just to be aware of that. The pregnancy ones, so the diclofenac and Celecoxib, that's going to be an interaction with warfarin, and in this case you will see an INR increase in that case because it's a kinetic interaction, so just to be a bit wary of that. It's not just an additive effect. There will be a metabolism effect that increases the warfarin concentration. Pregnancy, makes it a little bit difficult because first trimester there is an increased risk of spontaneous abortion, and that has been confirmed. It was a little bit unclear for a while there, so that's confirmed. Don't know much what we can do about that for someone that's been taking them, because obviously you can buy them over the counter as well. Oh, sorry, that was my interactions. I think we've almost covered it then. We don't need to cover that now. Lithium, again, to be careful and watching out for the increased risk of bleeding when it comes to using SSRIs and tramadol as well. I'm not going to go into any great discussion about the precision study, but it's only because it's out there. Obviously, Celecoxib is now funded, which is great, but we do have to be a little bit wary about the interpretation of this study. It was a massive study, 24,000 odd people in the study, reasonable age. The issues of the study, as you can see, is that the doses of Celecoxib at 200 milligrams daily is being wary because you could use up to 400 milligrams. It's licensed. So just remember in this study that it was 200 milligrams. The dose of naproxen is reasonably high, and the dose of ibuprofen I think is particularly high. We very rarely see anybody on that sort of dose, I would imagine. The other one is that 68% of the people stop the drug during the 20 months of it. So that would probably be a fairly good indication that the non-steroidals weren't that agreeable with patients. It was either because they weren't effective or because they had adverse effects. The primary endpoint, again, it just really showed that there is a risk. There was no placebo, so we can't say how much greater that risk was of having a cardiac event, but this was the 2.8 for those that stayed on therapy. Celecoxib, as we talked about, had less serious gastro complications. I've heard people sort of saying, oh, Celecoxib's good because it's not so bad on the kidneys. That's compared to ibuprofen, and going back to the dose of ibuprofen, that's compared to a very high dose of ibuprofen. There was no significant difference in the renal effects between Celecoxib and naproxen, so that's still problematic, just in case they're talking about that. So looking at what we're going to do if we're looking at risk mitigation when we're looking at non-steroidals, obviously low dose, sort of goes without saying. We tend to jump in, and particularly for our older people, looking at 75 milligrams, say, once a day, maybe twice a day. And we jump into that, but we don't know that that's the lowest effective dose. So while it might be convenient, it's also possible to use 25 milligrams up to 3 times a day, or using naproxen 250 up to twice a day. So you're ending up getting a lower dose, so you're working within a better margin of safety. As people perhaps get on and you're going to end up with those with more chronic pain, then okay, you might switch that to 75 milligrams. But it's worth the person testing for themselves. What is the dose that's the minimally effective dose? A bit like the paracetamol. Take 25 milligrams 3 times a day for the next 5 days. 5 days is a little arbitrary, but do that, and then either it's going to be effective and the person's in control of titrating that down to see what the minimum effective dose is, or if it's not effective, you'll change therapy. Adding the PPI or using Celecoxib for the gastrointestinal, avoiding with those drugs, SSRIs, tramadol, and the other ones like the aspirin, warfarin. Renal, I don't think I can emphasize the way enough about avoiding dehydration. The thing about doing serum creatinine for renal function is that's quite sensitive to hydration as well. And so if someone does become dehydrated, it can be a false trend thinking that their renal function's deteriorating. So if someone's going and you want them to get their blood test for renal function, ask them to make sure they take a couple of good glasses of water a few hours beforehand, but somehow make sure that they're hydrated. Not overhydrated, but actually hydrated, because, as I said, the serum creatinine is quite sensitive to the hydration status, and you can be getting some false readings on renal function. Monitoring renal function at 7 to 10 days, particularly in the very at-risk group. As I said, for Māori and Pacific, I've been surprised at the number where I've seen quite a distinctive reduction in creatinine. We wear the triple RAMI. Cardiovascular-wise, we don't know because there's no studies, but certainly make sure you've optimised the treatment for cardiovascular risk if someone's going to end up being on non-steroidals. Right. Yeah.
Linda, just before we go on to opiates, there are a couple of questions about the NSAIDs. One of them, do you still recommend taking these with food?
Now that's really controversial, and the answer is generally no, it doesn't actually make any difference. Most of the effect that is occurring is to do with a systemic effect. So it's not like the tablet's sitting in the stomach and eroding it away, pretty much. So it's not really a direct effect. If they want to take it with food, maybe they think it's going to reduce dyspepsia, but generally not. But it's a way of remembering it, and if the person feels better, that's fine.
And as you've discussed,
I don't take mine with food. I try and swallow mine with it.
As you've discussed, when you're prescribing NSAIDs, you need to look at the whole patient. So in terms of the risk factors and sensible use, it's not just each individual matter. There's been specific questions that have come in about, say, a 65-year-old with good creatinine clearance. Would you limit the NSAID use that because they're older yet they have good renal function? Now, I guess what you've been trying to say in your presentation is that you have to look at every factor. You have to look at everything that's going on for the patient and make a decision based on that.
Yeah, I feel a bit, having gone through all these terrible things about non-steroidals, I feel sometimes we leave people in pain by withholding something that's effective. The problem we have is trying to describe that risk to the person so they can sort of make that decision. So someone of 65, I don't consider particularly old anymore. Maybe when you're getting to 75. And I'll have to confess that after a lot of negotiation, we've sort of used non-steroidals on people that are getting into their late 70s, low dose with the risk mitigation, because it works, and that person quality of life was really important, but it does require the discussion. So 65 are good renal function and they're not going to be at greater risk of bleeding, and their renal, you've done their creatinine at some point and their renal function looks good, I wouldn't stop it. I'm not 65, but if I was 65, I would still take them if they were going to give me pain relief.
Yeah, it's relating it individually to that clinical context. Yeah. And
I'm 65 now.
In terms of the different anti-inflammatory or NSAIDs, are there any significant difference in terms of which one you would use or which one has a lesser side effect profile? It doesn't sound like it from what you've said, but do you have any comment to make to that question?
Oh, it's very hard to break habits. Technically we should have been using naproxen when we thought there was less of a problem, but we still have diclofenac as our most popular one. It's a little bit of a COX-2 and drag, which is why there's more problems with the higher doses when it comes to cardiovascular risk. Ibuprofen, I probably get myself in a lot of trouble. I'm not a massive fan of it because, if you're using it longer term for any anti-inflammatory effect, it's not working. I feel we're still unsure about whether there's an interaction with that and aspirin. It's 50-50 at the moment. I don't know if people are aware that for some time there's been this debate about if you use ibuprofen and aspirin, the ibuprofen has an interaction that reduces the effect of aspirin. And I just don't find that it's as perhaps as effective, but then other people use ibuprofen a lot and do. So I guess I'm saying it doesn't really matter. What your experience with is going to be the most important one.
Sure.
Celecoxib is probably not as effective at the 200 milligrams. There is a meta-analysis out there that gives you an indication, and that's why I was worried about people going up to 400 milligrams.
Right.
Mm.
One comment on prednisone use in gout. Someone's written in saying that their experience as Māori in Pacific Island, people respond less well to prednisone than they do to anti-inflammatories. And would you consider using a higher dose of prednisone to avoid anti-inflammatory use for these guys?
It's interesting that they hadn't found it quite as effective. I mean, and I was talking about this, I must admit, I was talking this to my gout guru, Linda Bryant. We're talking about it, and I'd be using the 40 milligrams 3 times for 3 weeks, for 3 days, 40 milligrams 3 days, and then 20 milligrams. There is a dose calculation, so it could be up to, I'm trying to remember, is it 0.5 milligrams per kilogram? So for some of these people, you might really be getting up above 40 milligrams. I don't tend to, but that might be an issue if you look at the dosing of 0.5 milligrams per kilogram.
Okay.
I'd be a bit worried going above 60 though.
Yeah, side effects. Yeah.
That might do it. And getting in early as well with the gout.
Great.
I find one of the things that horrified me the most perhaps was about a week or so ago when someone came in and this mother dragged her son in, he was in his 20s, she dragged him in and said, oh, and my other son's got gout as well, and we've run out of the diclofenac. And it was sort of a family sharing diclofenac, and that really does worry me when these medicines get shared like that. And I mean, it's understandable, and we know that it happens and that sort of thing, but it was when sort of the whole family's run out of diclofenac and they've been sharing it around.
Yeah.
So that.
Thanks, Linda. We'll let you go on to opioids, I think.
Right. Okay. Well, the opioids are quite short, or you have to just read some of the American things. I think even Trump's come out to say that they're going to have a war against opiates or something over there, as opposed to North Korea. They're having it against opiates. Again, like everything else, the evidence of benefit is quite poor. And what this comes from JAMA, and you can tell because it's an American, they wanted to stop using such things as post-operatively. They've been wanting to stop using the opiates, and this one's actually in an ED department. Now, acute extremity pain for them is anything from the shoulder to the fingers and from the hips to the toes, so it covers most of things, didn't cover the back. Looking at this study, they found that obviously ibuprofen plus paracetamol was as effective as throwing in oxycodone. And that oxycodone dose of 5 milligrams equates to about 7.5 to 10 milligrams of morphine, because I'm more used to working in morphine equivalents. So you can see there, for that, there was no significant difference. So this ibuprofen and paracetamol. Just taking a slight sidetrack, because people are probably going to ask about those combinations. The evidence for the combination of a non-steroidal and paracetamol is really conflicting, and I think in some extent it's probably the way that might be introduced. There's studies that show that it's better than either drug alone, and those that show there's no difference. I don't think there's any synergistic effect between them. It might be a little bit additive though, but not greater than the whole. So let's just talk about those combinations. Ibuprofen and codeine has become a problem because of the abuse of codeine, and people have been taking it for the codeine and stuffing up their kidneys by taking too much ibuprofen. So that was an aside which I probably forgot to mention before. Looking at lower back pain, there are no studies of the low potency opiates or even higher potency opiates in acute lower back pain, a placebo-controlled study. So it was quite hard to find anything there. But the adverse effects, or the lack of effect, sorry about the typo, in chronic back pain indicates that they're of marginal benefit even in chronic back pain, let alone acute. Now, the concerns, let's what to say? Well, let's start with the codeine and tramadol, who is going to be our ones that we do go to. They're both prodrugs, so that means that both of them need to be metabolized to the active metabolite. In the case of codeine, it's metabolized to morphine. So 10% of codeine is metabolized to morphine. That's why it was so good for making home bake many years ago. For tramadol, it's again also metabolized into something called M1, which is the active metabolite. So in 7% of the Caucasian population, they're very slow at metabolizing this. And so it doesn't get metabolized to its active effect. So we're going to have a lack of effect for the codeine and tramadol. So some people will tell you, didn't touch it, didn't touch the pain. So they could be what we call slow metabolizers. Possibly of more concern, particularly perhaps where I work, where we've got a lot of refugees, 25% of the people from like Somalia and Ethiopia, around that area, plus the Middle East, are ultra-fast metabolizers. So this group of people are going to metabolize codeine to morphine really quickly, and there's a great risk there of respiratory depression and that toxicity, as well as the other toxicities. And the same with tramadol. It will rapidly get metabolized into its active moiety, and they're getting a lot of adverse effects from that. So just to be aware that it is a problem with both the medicines. They're metabolized by the same cytochrome people, so 50 enzyme system, 2D6 for all the pharmacists out there. So you're going to have the same problem. There's no point changing from codeine to tramadol if these people are going to be a poor metabolizer. The other problem is the American one that I love. We don't have addiction habituation there. We have opiate use disorder, and I don't think we need to go much more into that. The benefit, if there is, if you're going to use like codeine and tramadol, the benefit is in that less than 12 weeks, remembering that other than that, if we end up with escalation, there's also the risk of habituation. It's very hard if people say, I always have to take that. It helps me sleep. I take my tramadol. It's good if it's stopping the pain, but if they're using it for sleep, it's a bit more problematic. So watching out for habituation. The driving, very, very much into, I think, the ads on TV now, drugs and driving. Opiates, within the first day or two, there might be a problem with a little bit of cognition or confusion for some people. Generally, after 3 days, there's no difference between their driving issues. So while I've put driving in there, if someone's going to take codeine or tramadol acutely, certainly I'd be worried about them driving sort of for the first day or two. They might feel like it's okay until they go and try and park a car. I've done that with some cough medicine, and you actually find that's a skill that you don't have any longer. So be very wary about driving, and if these people are going to be doing a lot of driving, if you give them the codeine or tramadol. Of course, the other problem is driving can be just as hazardous if a person's driving and they're in pain, and that's why the studies have been quite difficult, because pain itself turns you into a pretty bad driver. Adverse effects, I'm sure you're all familiar with. It's not going to be a surprise to you. Tramadol has extra adverse effects, however, and that's the increased risk of seizures. So if anyone's got, say, head injuries or is prone to seizures, is on other medicines that reduce seizure risk, then tramadol could be more problematic when using that. The other one, as we've talked about sufficiently, is because it's got the 5-HT reuptake inhibitor action, so that SSRI action, it's got an antiplatelet effect, so there is an increased bleeding risk, primarily with other drugs that can cause bleeding. So something to just be aware of. The interactions, again, they've come up. It's for some of the studies that they looked at in the States, the deaths by the opiate-related deaths, 40% of those people also had benzodiazepines on board. And I remember when I first started out, it used to be a little bit of a thing in ED. If you gave, the house surgeon would give someone morphine and Valium, say at that time, and the person would go into respiratory arrest, and they'd have to bag them. before we had the antidote to the benzodiazepines. So just to be wary of that is definitely try not to mix opiates and benzodiazepines. For the same reason that our Middle Eastern population tend to have 25% who'll be toxic with using tramadol and that. The same sort of system means that if you use fluoxetine or paroxetine, then you'll get reduced analgesic because you're inhibiting the metabolism of codeine and tramadol. And one that's coming out at the moment is the gabapentin. It is actually in the data sheet, but there's an increased risk of respiratory depression. Not that I expect many of your acute pain people to be on gabapentin as well. And again, tramadol. Mixing it with serotonin. We talked about the increased risk of bleeding, but remember there's also the increased risk of serotonin toxicity. So if someone's on their SSRI and they're on tramadol and they start getting that sleeplessness, headache, bit of agitation and tipsiness, think serotonin toxicity, not necessarily, that one of those drugs is not working. Just think you've got serotonin toxicity. And it was trendy in the hospital for a while to give tramadol and ondansetron. They antagonize each other, so you're going to get less analgesia and probably more vomiting. So don't mix those ones now that we can prescribe that in primary care. I was asked about muscle relaxants just today, in fact. What should we do? The evidence for muscle relaxants is pretty poor. You probably wouldn't go straight into saying, let's use a muscle relaxant. So that's meaning orphenadrine and benzodiazepines. It's very individual. There's lots of adverse effects that go with them in terms of that versus the benefit. Orphenadrine, if you really, really, really think it's a good idea to use one, then only prescribe a small number of tablets and make it PRN. So don't have a whole lot of tablets floating around. 10 to 20 tablets would be quite adequate for people to try. And as we talked about benzodiazepines, preferably not. They're really sedating people more than anything else rather than muscle relaxant. And they certainly have a problem with driving and you don't become tolerant to it. So if anything, if someone's in really, really acute pain and you think there's a massive muscle spasm there when you've tested, no more than 5 tablets. Otherwise, people keep coming back for more. So, looking at the time and looking at our case again. If we're looking at Ms. Y, so she's young, she's healthy. The thing is that she's got severe pain. So if you'd look at her, she really does need to take regular non-steroidal probably and paracetamol. She hasn't got any risk factors as such that we're worried about the non-steroidal. So it's severe enough you'd give both and give her a PPI, even though she's young. Email or phone in 1 week to see how she's getting on and start talking about titrating backwards at that point. If it was less severe, as I think we've pretty much covered, if it was a less severe situation, try regular paracetamol and give them the non-steroidal to use if needed. If they've got a sleep problem at night and the non-steroidal works, then that's when you might decide on a SSR, a slow release preparation. Okay, it depends on the person's experience. Some people will come in and be like the patient I had who found paracetamol work, but they'll be saying, oh, it's only paracetamol, either I've tried it, it never works. So it's going to be up to you to look at the individual person. But always start a little bit for those first few days of having it regularly and then tell them to taper off from there, giving a good time to taper off. Don't let them go on forever. And that phone call does wonders. If you give them a ring, it also you know if things are not going well. Here's our 67-year-old. Sorry, not 65 or 75, right in the middle. Basically, you're going to have a baseline of these people for a renal function. If it's over 50, in that case, it's a 50 mils per minute. That's okay then to keep going with using a non-steroidal if that's all we're looking at. And have a retest of the renal function in 7 to 10 days. If it's less than 50 mils and the person seems reasonable to you, then obviously looking at codeine or tramadol. Take their cardiovascular risk, add 20 to 50%. Now, if their risk is right up there at the sort of 20, 25%, that might be enough for you to consider using codeine or tramadol as above. Makes it difficult if they're also on aspirin. So you might have to move away from tramadol and think about codeine just because of that bleeding risk. If you're just looking and this 67-year-old has a moderately high bleeding risk, then you'll think of Celecoxib. If not, obviously making sure you have lower doses, add a PPI, and if it's less severe, back to the usual regular paracetamol. So I don't know if that one makes complete sense on that slide, but it's going through those three things. And then even if you say, okay, this person's okay for a non-steroidal, make sure that you don't go above those maximum doses and always add the PPI. And I think I think I just covered that reasonably well because we had the question about it, was I would be more emphatic about checking renal function in the sort of 7 to 10 days to see what's happening, and I would try and keep the dose of non-steroidal low. If the person's got sciatica, basically amitriptyline or nortriptyline, I think that was pretty well covered in NNT of 10. I think that was covered for our chronic pain person. The next thing is the sleep, fatigue and anxiety, and this is where we're starting, the person's coming back and you're starting to find it a little bit more difficult. I really can't sleep with this back pain and I'm getting all those problems that go with it. Review the analgesia, because the sleep's because they've got poor analgesia probably. Rather than adding and just accumulating and adding more and more and more, if something hasn't worked, just switch. If the non-steroidal wasn't working, switch. If the opiate wasn't working, switch. If paracetamol wasn't working, stop it and try something else. So just don't keep trying to accumulate. And that's where the situation with the combinations, there is conflicting evidence. If the paracetamol helped and it reduced the pain by 50%, then you might want to continue it and add a non-steroidal. So it depends on how effective it was in the first place. So very short term for the problem with sleep, resulting in fatigue and a bit of anxiety, making sure they've used the non-pharmacological recommendations like the pillows between the knees. All those things you're far more knowledgeable than I am on those. But do try and avoid the opiates for these people because they then tend to it becomes more habitual for them to use it. So you might end up giving them 5 tablets of benzodiazepine, but no more, and being very clear that that's it because they should be getting better after that. Now, a quick one for the dental pain, and I put John Buckersfield up there because I would really know very little about dental pain, except he was a very amazing guy who came and told us about it. Bottom line, if someone comes in with dental pain, and this is one of our common presentations, they are going to need a dentist because if they've got pain, there is a problem with their tooth, and it's going to get worse without therapy. But this was a really good recommendation, and we use it a lot where I work, which is if it's sensitive to cold, ask them, is it sensitive to cold? Then the pulp's okay. And so just low dose non-steroidal of your choice, low dose. And then they can use something like Sensodyne Repair and Protect. If they say, oh, it's sensitive to when I drink hot coffee, then obviously the pulp's starting to die and you're going to want to treat with some antibiotic as well, in which case metronidazole is a really good idea. If you touch it and you say, oh, when I bite on it, it's just agonizing, that means you've either got dead pulp or dying pulp and inflammation, so then it's non-steroidal plus a metronidazole for 3 days. And dry socket, which is very painful. Basically hot salty mouth baths for 10 days. So that was the my thanks to the dentist. That's not an area of expertise where I actually am at. So key messages. strangely, you're more important than the drugs are. So it's your approach, your education, your setting of expectations and explaining to people that's really going to make an effect on whether the drugs work. But also, by the time you've done that, people might be a little bit less reliant on drugs. When it comes to the back pain, then maintaining activity is the important thing. Paracetamol, it is still effective for acute pain. Try it regularly initially. If it doesn't work, a person saying it's not touching it and I've taken it, you know, 3 or 4 times a day, then move on. If they say it's sort of okay, but I'm getting a bit of pain, you might then add a non-steroidal. There's the dosing issue. Non-steroidals, same thing. People think they're really great, so make sure that in every situation that you've done the risk mitigation, you've gone through it, and not that I'm that risk averse, but make sure you've recorded what you've done by way of risk mitigation for these people, so that if they do happen to end up in hospital, you say, well, we did all these risk mitigation strategies. And for them, getting good pain relief was far, far more important than what they thought for the risk of perhaps renal function. Checking renal function, be alert for the triple whammy, and it would be worth avoiding that at all possible. So avoid it by changing your blood pressure lowering tablets usually. Opiates, as soon as they're starting to be used for acute pain for more than 3 months, it's time to change strategies. It's time to make referrals and get some help, and avoid using them with benzodiazepines. PRN medicines, didn't actually touch too much on that, but particularly older people or stoic people. We've done questioning people. There's someone, you know, you say to the person, you've been told to use this up to 4 times a day for pain. When would you use it? When people come out of hospital, sometimes we see them on tramadol and paracetamol and sometimes codeine or morphine. We see them on this real combination of use this for pain if you need it. In many cases, try and be a bit more specific, a bit like the Goldilocks, you know, this is too big, this is too small. Particularly in the early stages, try and be specific about when to use the medicine, when not to use it. Otherwise, people will let themselves get into quite severe pain, and then they won't do their activities, or they end up taking a whole lot. So try and be specific. Older people are very stoic, and they don't tend to take their medicines as they should. And also thinking about prescribed small amounts. It's nice to say, well, have this and always have some on hand, but it's not giving a good message about when you expect the person to stop using. Plus, it's really handy for them to come back to you because you want to know how they're getting on, and you want to know if they are getting to the 1 month or 2 month stage and still having problems. So try not to prescribe massive amounts. Keep it quite reasonable.
Thank you.
And I think that's it.
Yeah,
Did I finish on time?
We do. We have a couple of questions. We might just quickly do a couple of these. There's been some questions about the pain ladder and how that appears to advocate adding in therapies on top of each other as opposed to monotherapy, as per your discussion, and how you see we should be approaching this.
Yeah. So let's start with the paracetamol. If someone says it just isn't touching the pain at all, then don't persist with it. We've seen enough in the evidence to say that for some people, paracetamol simply doesn't work. And so in that case, you'd say, okay, we'll stop that and we're going to move on to the next step. If they came in and they said, oh, you know, the paracetamol, it's okay, it's sort of working, and, you know, I can do a bit more, but it's just, I've still got a fair bit of pain. Then in that case, you'd sort of think about it and you think, okay, in that case, there is some benefit. So in that case, I would add, say, a non-steroidal, which is the normal sort of steps. So you would, in that case, add something. But it's depending on how it worked in the first place for the person. You don't want them taking something that doesn't work. If for some reason you were sort of started off on codeine or tramadol, and they came in and said, oh, it's not working at all, you know, I might as well throw it out, it just makes me feel sick, then they might be one of those people that's a poor metabolizer. There's no point continuing and adding something onto it for that situation, so you might as well change. So I don't know if that makes sense, that it's an individual, but sometimes we just see people adding and adding and adding without going back saying, well, was that drug one of the ones that was going to work for that person or not? As I said, if there's some benefit, if you get a good, 50% response or something, then it is working, and you'll add something. If you've got no response to it, just switch it. Do you think that makes more sense, Helen? Sorry.
No, I think that does, and I think that answers adequately. There's a couple more things very quickly. One on the use of Nefapan and the possible use of gabapentin in acute pain, and what do you have a comment to make on either of those?
Oh, I remember when I first started, so we're talking a long time ago, Nefapan was really the this is the new one, and went through it with a clinical pharmacologist. It was one of the dirtiest drugs out in terms of adverse effects, because it affects the parasympathetic nervous system. I'd be putting that down into adjunctive agents of last resort. Give it a go, but I think the adverse effects generally are bad. I do know one patient that's on it 3 times a day and can't get her off it. So maybe it's one of those very small minority that has a benefit, but it's a pretty dirty drug when it comes to adverse effects. So I'd put that as a last resort type one. Okay. And think about those parasympathetic nervous problems.
Okay.
And the other one's yes, having talked all about how good the post-op pain control is and things like that. For severe pain, the anaesthetists are starting to use morphine plus gabapentin post-operatively. And that's probably why we know more about the fact that respiratory depression is a problem when we use gabapentin with morphine. For acute pain, I haven't seen a lot of it. It makes people really, really drowsy sometimes. You've got to start building it up from a low dose. I possibly would put that ahead of Nefapan though, in terms, but I'm not experienced with it. It would be interesting to get some experience with it. Okay. But the fact they use it post-op with morphine, the anaesthetists have found that that's beneficial at that point, severe pain.
Okay, and the very last thing here, there's some discussion about other opioids like OxyContin and fentanyl in an acute setting, and that they can be highly effective, but obviously there's the addictive potential and the side effect profile. What's your comment on that?
That's where, if you read a lot of the experts on this, being the Americans, they have found that's been the issue, where people were getting oxycodone for dental pain and things like that. The main things to remember about it, I mean, if someone's got really excruciating pain, but we know more about morphine, okay? There's concerns about it in renal impairment and things like that, but we're talking 30 mils a minute renal impairment. So morphine is something we know really well. We know about the dosing, we know the issues. OxyContin is about 1.5 times to 2 times as potent, so watch out for the dose equivalents on that one. It's no better in renal impairment, even though that's what it was sort of marketed on. And it seems, because it's a trendy drug, and I know this is not the only reason people get addicted, but it has got that aura about it that it's a major problem. So I'd probably steer clear of it for that reason. Fentanyl is really good for people who have got renal impairment, severe renal impairment, and that's where you'd use it. I'm presuming they're talking about the patch rather than using the injection in some way. But then it takes a long time to actually be absorbed for something acute. I think if you're starting to think about the more potent opiates for acute pain, then it is sort of getting a bit out of the realm, and that it is the addiction that is the main problem that's coming through. And we should perhaps learn from the States about that, and the fact that in some of those studies and the post-op studies and that things like paracetamol and non-steroidals are as effective. Take that JAMA article where they did it in the ED for the lower extremity. That pain rating there was 8.7, I think, was the pain when they came into the ED. So that's 8.7 out of 10, quite severe. And using those combinations for both of them, it went down to about 4.5. So that gives you an indication. Oxycodone versus paracetamol, ibuprofen and paracetamol, so those together, same effect.
Great, thank you. Well, thank you, Linda, very much. We really appreciate having you come and talk to us, and it's been really informative, I think, both the pharmacological side but also looking at the clinical context for the patient, which I think we all have to manage in our day-to-day practice. And that's the end of our talk tonight. We have obviously, this is the last talk for the year for our Med Talks, but we have the symposium coming up next year, and I think the early bird registrations are all open, so please come along and join in. It's going to be an amazing event. Thanks very much, everyone. Thank you, Linda.
Thanks. Bye.